Here we are at the end of day 2 of ATA. John, a big few days, in fact 4 days really.
Yeah.
So highlights for you?
I think it's been amazing to see the scale of things over here. So looking at the number of vendors even in the trade hall, the number of people doing some type of telehealth. I mean, they talk in the tens of thousands of patients seen, or if not more sometimes. And then getting a sense of the way it's approached like a market by a lot of people. Mm-hmm. So trying to draw in customers, and that's a whole different flavour to what I've felt about telehealth, say, in New Zealand. Mm-hmm. But seeing what that leads to and what that creates is quite interesting.
So money is the motivator a lot of the time. It's generating income.
Yeah, I mean, I think if you ask people directly, they would say good care is the motivator. Mm-hmm. But you can see that the way the health system's set up, it's very easy for money and the way the money flows to be the enabler. Mm-hmm. There are people who seem to be working out a way to bring in business, and that's bringing in patients.
So I mean, that aside, there's a lot of people doing it well. Why are they doing it well? What do you think of the triggers that make it well? I mean, having the money is obviously, but what else is the key factors?
It seems like there's been some good direction from on high. So the aim of the federal government to change the way healthcare is delivered. So people have talked about moving from process-based reimbursement or procedure-based reimbursement, where you just get paid for what you do, to outcome-based reimbursement. Mm-hmm. So you get paid for what you do well, and that fits with telehealth, because that, for a lot of people, that's them being looked after better. And then there's things like the FCC mandating the way people are able to get access to broadband, and so trying to get this idea of parity, where people in rural communities who don't have such a good access, who may have to pay more, get that cost evened out for them.
Yes, and I've seen that as well with the grants that you apply for. You can get a number of things paid for because of the disparity. So that kind of is the equaliser.
And you know, some of the really big healthcare organisations are so big that they can allocate enough people resources to really get something humming and running well. So the resource centres look great, and what they produce and the kind of input they have into everyday people trying to get telemedicine going is really valuable.
Yeah, I suppose for me that is, I mean, I was here last year, saw what they were doing, and this year, again, my eyes have been opened again, and they run some great programs, and the training programs they run are particularly good for telehealth coordinators. The resource material, and it's all about sharing. They're very keen for people to, it's kind of almost the opposite of what we were talking about before, about they get funded for the more people that take up telehealth, so they're giving freely, and some of the information there, because here I see a lot of people selling things, a lot of people wanting things, but there's it's the getting the bit in between, and there's I've had some discussions with some people that have said that they've spent hundreds of thousands of dollars on widgets and stuff, but when they've gone to implement the whole thing's fallen over. And the Telehealth Resource Centre say that there's the 4 things to make a great telehealth program. Clinical leadership is the number 1. Executive leadership buy-in is another thing. A telehealth coordinator, full-time, that manages the program, and IT in the background, just making sure things are happening. And that's the things that's been the thing that I've learned about. So other things that you've come across in your specific field of paediatrics?
So some really good stuff about doing neonatal intensive care and adding telemedicine to that. And so there's quite a good presentation called ICU Baby. So babies in the ICU who are often for that reason separated from their parents or the rest of their family. And it's something as simple as them putting an iPad on top of the incubator with the camera pointing at the baby and streaming that to the family's home. They did put quite a lot of thought into setting that up, and so they figured out that people shouldn't be able to just kind of look in at any time. That was something that was difficult for the nurses to cope with, and so they've got a booking system for letting that happen, and that is just good, really practical care of people. There's been some good stuff and more coming this afternoon about acute paediatric care. But the other thing that has been really interesting to watch is the debate about the urgent care out in the community, and I guess that's the business model of people setting themselves up to draw patients in from everywhere who want to be seen acutely, and the debate they're having about whether or not you should be able to prescribe to patients you've never met before, and so Texas has said no, and Texas is getting sued by one of the big companies that wants to be able to do that, and I guess it's really putting under the spotlight the regulation, and so how telehealth is regulated here. So rules that keep people safe, but that don't restrict a new way of practicing. And we're going to have those same type of debates in New Zealand. And I imagine on our smaller scale, it'll be easy to get the right people talking so that we can figure out something that meets the needs of keeping patients safe and well looked after.
So who would those people be? Would it be Medical Council?
The Medical Council, the New Zealand Medical Association, the patients,
Yes.
the people who want to create a service by telehealth, and in particular, the ones who want to do it all by video. And so we're getting those, and it's important, I think, that they get to put their case and they get to explain why they want to look after people that way. And if there's a good discussion, they'll then get to understand what's expected of them. And I can see that being a lively debate, but one that should let us have a way of regulating with flexibility. Yep.
Okay. So take-home things from here, like for you. I mean, there's the paediatric stuff and the regulatory stuff, but is there any other take-home things that you're going to bring back to New Zealand?
Yeah, so I guess we need to really start thinking about how we're going to connect or integrate video with our electronic health records and things like patient portals, because there's a lot of undone work in general practice, and if the things that will really let that happen are helping guide GPs about the right patients to see, and then having really easy to use mechanisms for that to happen. And so that's probably all going to be software in and out of patients' homes and general practices. And if it all fits in with medtech, the hospital, the DHB electronic health records and the patient portals, it'll work really well.
Okay, anything else?
The other take-home things, a really nice pan-tilt zoom web camera.
Yeah, we've got the order in, we're about to,
And in fact, one of each of the gadgets that are here.
That's right.
Would be great.